and mood symptoms and ways to tackle that, hormonal and non-hormonal. We will be recording this session, so it'll be available afterwards as well. And there'll be some time at the end for some questions. Right at the end, we'll have some time. Okay, so I'm just going to share my screen. So I will start by covering what is the menopause. And for the purposes of this discussion, I'm going to be using terms like women and female when referring to menopause, as these are the terms most often used in research and clinical context. But I acknowledge that people of all genders and gender identities can experience menopausal and perimenopausal symptoms. So what is the menopause? Menopause is a natural milestone. It's a natural biological milestone in a woman's life, and it happens when the ovaries stop releasing eggs and produce less estrogen and progesterone. And this is a point in time when menstrual periods stop permanently, and it marks the end of the reproductive years. There are three main stages of the menopause. There's the perimenopause, and this is the time leading up to the menopause, usually begins in early to mid-40s, sometimes earlier, and it can last many years. And then there's the menopause, which is just defined as a point in time when a woman has not had a menstrual period for 12 consecutive months. And then you can get different types of menopause. So early menopause refers to menopause occurring before the age of 45. There's premature ovarian insufficiency, and this happens when the ovaries stop functioning properly before the age of 40. And this can happen for many different reasons, genetic reasons, autoimmune conditions, infection. Often the cause is unknown. And it can be caused by medical or surgical intervention as well, such as chemotherapy, radiotherapy, or the surgical removal of the ovaries, known as a bilateral or single oophorectomy. And then the post-menopause stage comes after menopause, lasting for the rest of a woman's life, when symptoms tend to reduce over time during that time period. But at any stage of the menopause, with any cause, early identification and management are crucial for symptom relief day to day and the long-term health, especially for bones and heart protection. So this graph shows how hormone levels change throughout our lives. And for most women, during the reproductive years, the brain and the ovaries have a very nice, civilized and harmonious relationship with the pituitary gland in the brain, sending nice, polite messages to the ovaries, which usually comply and produce balanced levels of hormones, resulting in predictable cycles most of the time. But at the end of this time period, in the perimenopause, where you'll see things looking a little less neat, the ovaries start to get a bit tired and sluggish, and the relationship between the brain and the ovaries starts to break down. And the hypothalamus and the pituitary gland in the brain start to get very cross that the ovaries aren't doing what they're supposed to be doing, and they start to shout down at the ovaries. And then the ovaries either respond by overreacting and producing way too much estrogen, causing these big surges, or they fall silent and give the brain the silent treatment and produce very little estrogen, causing levels to drop very suddenly. And this can cause a very chaotic picture with very chaotic changes in estrogen levels, which can cause irregular bleeding, irregular cycles, and very erratic symptoms. Women who undergo surgical or medical menopause skip this this stage, and they're sort of plunged straight into menopause. We have three really important female sex hormones: estrogen, progesterone, and testosterone, and they all play a really important role in the menopause. But the loss of estrogen is the main driver of most symptoms, so I'll talk about that first. Estrogen is primarily produced in the ovaries, with smaller amounts coming from the adrenal glands and fat tissue, and it has widespread effects on nearly every organ of the system. It regulates the menstrual cycle, and it's essential for the development and maintenance of the reproductive system. But beyond reproduction, estrogen supports bone health, heart health, it balances good and bad cholesterol levels, and it influences fat distribution. It impacts the brain, supporting cognitive function. It influences mood and regulates body temperature as well. It also helps with bowel function and maintains the gut microbiome. It also helps to maintain the health of our skin, hair, joints and muscles, mucous membranes. It promotes vaginal lubrication and supports the urinary tract and the pelvic muscles as well. And because we have estrogen receptors on almost every cell of our body, once the levels start to fluctuate in the perimenopause and then drop, almost every part of us can be affected, leading to a very long list of symptoms. So this is the physical symptoms, and these can vary greatly from person to person, as with all symptoms of perimenopause and menopause, and they vary significantly in severity, intensity, and duration. Hot flushes and night sweats are among the most common physical symptoms, affecting up to 80% of women. And these are caused by changes to the hypothalamus in the brain, the body's temperature regulator. They often begin in perimenopause, peak around the last period, and then they can persist for many years afterwards. But we know that there are lots of other symptoms involved with the brain as well. And as hormonal levels fluctuate, so does the ability to maintain consistent sleep cycles. And poor sleep is reported by the majority of women that I see. And this can lead to significant fatigue, impacts daily functioning, and contributes to irritability and mood disorders, and can compound all other symptoms as well. Weight gain is also a common and distressing symptom for many women and can impact emotional health as well. Because as estrogen levels fall, fat storage tends to become more central, with an increase in internal fat. Additionally, muscle mass naturally decreases after the age of about 30. And less muscle means fewer calories burned. So weight can increase even if eating habits remain the same. Estrogen has an anti-inflammatory role, and so as levels fall, joints and connective tissues become more vulnerable, and this can lead to pain and stiffness for many. Periods can become more unpredictable, they can become heavier, they can become lighter. Changes range from being slightly inconvenient to completely debilitating for many women. And some people just aren't able to leave the house due to worsening pain and increased flooding, and can be really, really detrimental. Skin changes are also common, with reduced collagen production and reduced ability of the skin to retain moisture. And this affects the elasticity of the skin and leads to wrinkling, dryness, and itching. And fluctuating hormones can also trigger acne and eczema in women who've not had it for years, or perhaps have never had it before. And libido. Reduced desire for sex and enjoyment of sex is very common, and significantly affects quality of life, affects relationships, affects self-esteem, and this also impacts emotional and mental health during the perimenopause and menopause. We'll go into this a bit more later on. And you'll notice there are many more symptoms on this list, all relating to low estrogen levels. So psychological symptoms, these are very real and impactful, just as impactful as physical symptoms during the perimenopause and menopause, and they affect a large proportion of women. I think women, and often health professionals, perceive psychological symptoms as relating to our mental and emotional state, which is true, but there's a very real underlying physiological process going on and causing these symptoms, which is often misunderstood. Here we go. So psychological symptoms of the perimenopause and menopause are often one of the first reasons that women seek help actually in the perimenopause. And they're just as legitimate as other symptoms. The reason they happen, and this underlying physiological process that I was talking about, is that we have hormone receptors all over our brain, just like the rest of our body. Estrogen, progesterone, and testosterone receptors, and they play a really important role in brain function. They act as master regulators in the brain, and they directly influence our mood, our memory, our sleep, and how the brain responds to stress. And so a decline in estrogen, progesterone, and testosterone levels upsets the delicate brain chemistry and the stress response system. And that can lead to disruption of other really important brain chemicals. So serotonin, which affects mood, dopamine, which affects motivation and pleasure, and GABA, which helps to keep us feel calm. And this upset of the normal brain chemistry can trigger the emotional center, the limbic system, causing it to go into overdrive. And this triggers heightened anxiety as the first domino. Then our emotional alarm center, the amygdala, becomes hyperreactive, and this amplifies our fear response, making normal stresses and everyday worries feel much worse than normal, and they can become very overwhelming. And this then can trigger a physical surge. You get this inappropriate fight or flight response. Adrenaline floods in, and this can spark some of the horrible physical type symptoms of anxiety, palpitations, chest tightness, shallow breathing, feelings of shortness of breath. And this quickly loops with hyperventilation, and a panic attack can happen. And often these symptoms can be mistaken for cardiac type chest pain or even a heart attack. And it's not unusual for women to present to A&E with really distressing symptoms. Hot flushes are often talked about as the hallmark of menopause, but this picture of anxiety and nuanced anxiety is very common, far more common than people talk about, and is often the main driver for women to seek help in perimenopause. And this new onset anxiety in women who've never experienced anxiety before, or worsening anxiety and panic attacks in women who may have had some anxiety before, is a big red flag. And many women present with very specific anxieties in the perimenopause, such as a sudden fear of driving, for example, or even driving in particular scenarios like on the motorway. Women also experience irritability, mood swings, feelings of anger and rage, similar to PMS type symptoms. And sometimes the first thing that happens is that women start to notice a worsening of PMS type symptoms, which can become more intense. They can start to last longer. So even in women who are still having fairly regular cycles in the perimenopause, you can get this worsening of PMS symptoms that start to spill out into the rest of the month. And sometimes you have months that are worse than others, but that can often be the first stage. Some women experience severe low mood with persistent sadness, feelings of low self-worth and hopelessness, with a loss of interest and motivation. And during this time period, the risk of clinical depression increases, especially in women with a history of mood disorders. But most women, or many women, particularly in the perimenopause, these symptoms are quite transient, and women can feel extremely affected by low mood and anxiety at a particular time of the day, for example, in the morning, but then they'll feel that their mood lifts as the day goes on, and as the hormone levels change. Because we know that the fluctuation in estrogen in particular can be so chaotic and so variable during the day, so can mood and anxiety symptoms. And women will often come in and say, I know I'm not depressed, I know it's my hormones. And because estrogen plays such an important role in brain function, particularly in areas relating to memory, many women report brain fog, poor concentration, word finding difficulties, and short-term memory lapses as well. And the potential impact of this is huge. It leads to reduced self-esteem, reduced self-confidence. It affects relationships, work performance, and social interactions. And many women tell me that they stop seeing their friends and they stop going to social events because the symptoms are so severe. And of course, these symptoms can be multifactorial in nature, and they often are. At this stage of life, we're often sandwiched between lots of other stressors, like caring for young children, teenagers, young adults, and also supporting or caring for aging parents. And often at this stage of life, it comes with changes to career demands and general responsibilities. So a bit about impact on future health. Unfortunately, we know that after the menopause, long-term health risks increase due to the loss of estrogen's protective anti-inflammatory effects. There's a rapid loss of bone density, increasing the risk of osteoporosis and fractures. Arteries become less flexible and more rigid, alongside shifts in good and bad cholesterol ratios, and this can increase the risk of heart disease and heart attacks and strokes. Metabolism changes, and this can cause weight gain and obesity, insulin resistance, and an increased risk of type 2 diabetes. And there's growing evidence to show that menopause may increase the risk of cognitive decline and dementia. We've already talked a bit about the increased risk of mental health disorders, and women are more at risk of urinary tract infections and urinary symptoms. And poor sleep in older age is very common, which also in itself has long-term health implications as well. But it's not all doom and gloom, and there are many things that we can do to help mitigate these risks and improve day-to-day symptoms and functioning, and mark the beginning of the next chapter of life, which can be very powerful, often with newfound freedom and opportunities, and a celebration of our wisdom and experience, our life experience. And there's no single therapy that can address every aspect. So it's really important to take a multifactorial approach to managing symptoms of perimenopause and menopause. And every woman's experience is unique, and it really does require tailored management. There's no one size fits all. We know that making lifestyle changes and healthy choices is key alongside other management options. And this can reduce the impact of day-to-day symptoms and can improve overall health. And and reduce future health risks as well, which can be associated with menopause. And it's really important to focus on all aspects of health. But I think it's really important to recognise that for many women, in the early days of perimenopause, when symptoms are really significant, it's not always achievable to do all of these things whilst your symptoms are so debilitating. And often many women are better able to pursue healthier lifestyle choices if they have fewer symptoms to contend with. So I will be talking about hormonal replacement therapy options as well as lifestyle and how important they are altogether. So lifestyle medicine really matters in our holistic approach to managing perimenopause and menopause. And I like to position lifestyle medicine as part of the treatment plan always, not as an alternative to other options. And recognizing that small, realistic changes, small steps can make a huge difference in the long run to improve energy levels, mood, sleep, cardiovascular health, and bone health, and for long-term bone protection and muscle protection as well. For many women, the goal is not to power through perimenopause and menopause, but it's to reduce the intensity of the anxiety, improve coping strategies and mechanisms day to day, and to support day-to-day function. So practical lifestyle support is important, and it can help you feel more in control of your symptoms and less reactive to hormonal changes. These are 4 ways we often focus around these 4 lifestyle pillars as such. Healthy diet is really important throughout life, but in the perimenopause and menopause, what we eat really can influence the way that we feel day to day. And it's mainly about helping to stabilize our metabolism and stabilize our blood sugar and insulin control. And that can have a really positive effect on our brain health and on that brain chemistry that I was talking about earlier on, and the delicate balance, which is often the cause of all of the anxiety and mood symptoms in perimenopause. And so eating a diet that helps to manage blood sugar control and insulin control is key, really. There isn't a specific diet for perimenopause. We often talk about a Mediterranean style diet that is rich in plants. So eating as many different fruit and vegetables as you can, and having that as the predominant part of your plate of food is key in helping to stabilize metabolism. So we talk about a plant predominant diet. You don't have to necessarily exclude food groups. It's often what we eat with other things that helps the body process it and reduce inflammation. So a good aim is to make sure that half of your plate is made up of plants, fruit and vegetables. We want to try and avoid ultra-processed foods and things that spike sugar and then result in a crash, because that impacts the delicate brain chemistry as well. And one way to do that is just to try and eat the rainbow. There's lots of talk about trying to eat up to 30 different types of plants per week and having that as a goal. That feels quite overwhelming often, but it does include not just fruit and vegetables, but pulses, nuts, seeds, herbs, like garlic and ginger and all those different types of things. They all add up to the 30. But if that feels too overwhelming, it's just about trying to eat as many different fruit and vegetables as you can, really, and making sure that that's a really key part of all of your meals throughout the day. And that can often help to reduce inflammation and stabilize blood sugar. Regular exercise is also really important, and that can really help support anxiety. And again, it has to be achievable, so it depends what you're already doing. Many women who are not sleeping well find it really difficult to exercise or even go for a walk, and so starting with small steps is key. So it might be that you start with just going outside in the morning. You know, we know that having sunlight, daylight hitting the retina within a certain time period of waking in the morning can really help with mood stabilization, and that might be the first step, just to get up and get out of the house. And then we can start to stack on to that with a walk around the block and increasing activity as and when. And once you start to notice the benefits of that, it becomes easier. And then leading up to regular exercise throughout the week. And exercise snacking can be good throughout the day. So you don't have to go for a 5K run. You can just fit in bits throughout the day. So moving after eating, for example, moving after your breakfast, going for a walk, or at lunchtime if work allows, or whatever you're doing during the day. Just having some movement built in, even if it's just for 10 minutes, and you can stack that throughout the day. Some people find that doing some squats, some air squats after lunch, for example, can help, and that can help with metabolism and blood sugar and insulin control. And building up to strength training, building muscle mass can be a superpower in the perimenopause and the menopause. Good muscle mass, we know that building the muscle mass is really good for our skeletal health, our bone health, helps to promote good improved bone density and reduce the risk of osteoporosis. It also helps to protect our muscular system and reduces the risk of something called sarcopenia, to help maintain our mobility throughout life, and as we move into later stages of life, means that we can just maintain that activity level. But also building good muscle mass really helps with metabolism. So previously we've thought that we need to do cardiovascular exercise to protect our cardiovascular system. And that's really important too. But what actually can really help as well is building good muscle mass, because good muscle mass helps to process all of the sugar that we convert in the body, even with a low sugar diet. And that really helps to stabilize blood sugar and insulin levels and reduce the risk of type 2 diabetes, which reduces risks of lots of other conditions as well. So they all interlink and help with symptom control. Stress management is really important as well. Relaxation techniques through yoga, mindfulness, and breathing exercises can really help to calm the nervous system and promote GABA, which can help us to feel calm. Sleep hygiene, good sleep hygiene, can be really important, and a lot of people tend to know about trying to reduce screen time and having good relaxation before bed, and can be really, really helpful. So I am going to talk about HRT as well. It's a bit of a whistle-stop tour, but hormone replacement therapy, also known as menopause hormone treatment, or menopause hormone therapy, which is more commonly used in America, and international conversations and guidelines. And this is hormonal treatment to replace or supplement declining hormone levels. It's usually made up of estrogen, progesterone, and in some cases testosterone as well. And the type of hormones needed and the doses given varies from each person. There's no one size fits all. And the prescription and the regime needs to be individualized for the person. Estrogen, options around estrogen have come a long way from previously only being available as an oral tablet derived from pregnant horses' urine, to now coming in various forms, including pills, patches, gels, and sprays. And the current gold standard is 17-beta estradiol, which is a body-identical estrogen derived from the yam plant. delivered through the skin, which allows for direct absorption into the bloodstream, and so it bypasses the liver and reduces the risk of blood clots. And that's much safer for women with a history of clots or migraines and results in fewer side effects as well. There is an important role for oral HRT still, and some women do find that they need to take HRT orally to optimize symptom control, particularly in cases of poor absorption through the skin. Progesterone is also a vital hormone that helps to regulate periods. It supports pregnancy and the immune system and helps to regulate body temperature, sleep and mood. And in HRT, for women with a uterus, progesterone is crucial to counteract the thickening effect that estrogen can have on the uterine lining, the endometrium, and that reduces the risk of endometrial cancer, which can be a risk in women who take estrogen without progesterone if you still have a womb. And there's a body identical type of progesterone available as well, also derived from the yam plant. It's most commonly known as Utrogestan or Gepratix. And this also has additional systemic benefits for many women. So it can be really useful for women who have poor sleep. It has a natural sedative effect, and you take it last thing at night for that reason. But it also has what we call a neurocalming effect for many women. It helps to bathe the progesterone and the GABA receptors in the brain, and this can have quite an anti-anxiety effect for many women. There are also synthetic versions available as progesterone as well, with oral tablets, the coil, such as the marine coil, and there are patches available as well, combined patches with both estrogen and a synthetic progesterone in. And the way the progesterone is taken depends on whether or not you're still having periods, or whether whether or not you're having periods, so whether or not you take it cyclically or continuously. And then testosterone. Testosterone is another crucial female hormone, famous for being a male hormone, but also produced in large quantities by women. And that supports muscle mass, bone health and strength. It supports cardiovascular health, but also really supports cognitive performance, energy levels and sleep quality. And it also impacts our emotional and mental health as well. It influences our level of desire for sex, and the amount of pleasure we can experience from sex as well. When levels of testosterone reduce, some women find that they desire sex less often, or when they do have sex, it's less enjoyable as it used to be, even when they still desire and love their partner. It can also be difficult to achieve an orgasm when testosterone levels fall due to altered nerve function and reduced blood supply and flow to the clitoris, along with other symptoms of pain and dryness related to genital and urinary symptoms as estrogen levels fall. And estrogen as part of HRT can help with these symptoms and improve sexual desire, but many women find that adding testosterone that can be really beneficial. But it's also really important to remember to treat urogenital symptoms with some topical vaginal estrogen if necessary, and always use a good lubricant for sex. Testosterone replacement therapy is administered via the skin as a cream or a gel, and it does require blood monitoring, so baseline blood test and then monitoring throughout to make sure that levels remain within the normal female range. And current guidelines in the UK recommend that testosterone is only used for persistent low desire for sex. And we don't actually have a licensed product available in the UK yet, but we're hoping there will be one available either towards the end of this year or early next year. It's important to remember that HRT is not a form of contraception on its own. So it's always a good idea to discuss that with your health professional. And during perimenopause, it's still possible to get pregnant, even if your periods are irregular or if they've stopped quite recently. So that's important to remember. There are risks and benefits involved with the use of HRT. There are numerous benefits. So relief of day-to-day symptoms and improved quality of life, prevention of bone thinning and osteoporosis, reducing fracture risk and reducing cardiovascular disease, also reduced risk of colorectal cancer, improved glucose control and reduced risk of type 2 diabetes, as we've discussed, improved osteoarthritis rates. It may reduce the risk of dementia. The information around that at the moment is a little unclear, but we do know that HRT started within a 10-year window of the menopause, reduces risk of all-cause mortality. And we always need to talk about potential risks as well. There are two main perceived risks with HRT, the risk of having a blood clot and the risk of breast cancer. And unfortunately, due to a flawed research study, the Women's Health Initiative, which was done over 20 years ago, these risks have been misreported in the media and are mistakenly thought to be much greater than they actually are. As mentioned before, there's no increased risk of having a blood clot if estrogen is given through the skin as a patch, a gel, or a spray. And breast cancer risk, this is influenced by many factors, including age, genetics, family history, and lifestyle. The small increased risk of developing breast cancer associated with HRT is attached to older types of synthetic progestogens. And this can be minimized significantly by using body identical HRT. So body identical micronized progesterone, such as Utrogestan or Gepretix, carries no increased risk of breast cancer for the first 5 years of use. And of course, individual risk must always be discussed with healthcare professionals. But the guidelines from NICE are clear, and from the British Menopause Society, that for the majority of women, the benefits of HRT far outweigh the risks. So other ways to feel more empowered about menopause is attending things like that, learning more about symptoms and stages and management options, using reliable sources such as health websites, good books and reputable organisations, prioritising those life pillars that we talked about earlier, regular exercise, a balanced diet, good sleep, and to try mindfulness and meditation and relaxation techniques to help support emotional well-being. Joining support groups can be really helpful, having those social interactions. We didn't talk about that, but social connection as a pillar of lifestyle and a marker of health is really important. Discussing your symptoms, advocating for yourself, asking for help with your doctor or a menopause specialist, and asking lots of questions, being involved in your treatment, and speaking up at work if you're if you need adjustments, or if you're feeling like you're not being heard. It's really important to challenge myths and misconceptions about menopause in the conversations that we have. Taking up new hobbies and volunteering as a marker for health is really important as well, and that's really good evidence about improving emotional well-being, and just finding ways to feel more empowered and understanding your bodies. There are lots of common myths and questions, and I will run through these quickly just in case I might end up answering some of your questions with these. So when is the best time to start taking HRT? It's most effective if you start taking HRT during the perimenopause. So you don't have to wait until your periods stop before starting HRT, and don't wait until your symptoms are unmanageable. You don't have to wait until you're suffering before you ask for help. The most health benefits that we've talked about are in women who start taking HRT within 10 years of their menopause, or before the age of 60, but there's no age limit to taking HRT. So if you're past that time, it's always worth having the conversation, because there really is no age limit for taking HRT. I often get asked by women that saying that my periods are still regular, can I take HRT? Yes, you can. So going back to that perimenopause section on the graph with all the fluctuations, you can start to get really chaotic hormonal fluctuations before your periods start to change, or there might be very subtle changes happening, but you can take HRT if you're still having regular periods. Do I need blood tests? So most women over the age of 45 who have typical symptoms of the menopause don't need any blood tests to check hormone levels. If you're under the age of 45, then hormone blood tests might be advised. They can be a useful piece of information, but you can find that these are unreliable, and they're not always needed to make a diagnosis. It's usually a clinical diagnosis based on symptoms. But we do often like to test for other things if it's not a clear picture. So checking other blood tests to rule out other causes like thyroid function, for example, and many others. We do sometimes like to advise a DEXA scan to look at bone mineral density as well and look at risks for osteoporosis, and other screening tests like blood pressure, cholesterol, blood sugar, and keeping up with regular cervical screening and breast screening is also really important. And then often, what do we do if hormone blood tests are normal? Well, this can happen, particularly in the perimenopause. Hormone blood tests can look completely normal, even though you're having significant symptoms, and it doesn't mean that you can't take hormone replacement therapy. Side effects of HRT are common in the first few weeks. Then if they do occur, they normally settle quite quickly as your body adjusts, but disrupted bleeding pattern is quite common. Sometimes you get spotting in between periods. Bloating and breast tenderness are the most common, and some women do experience a little bit of nausea initially as well, but again, that usually settles quite quickly. And isn't it just delaying the inevitable? So HRT doesn't work by delaying your menopause. If you have menopausal symptoms after stopping HRT, then these symptoms would have been happening anyway. You would have been experiencing them had you not taken HRT. It doesn't just delay the inevitable, and you don't get a rebound of symptoms just because you've been on HRT. There's no time limit to taking HRT. You don't have to just take it for 5 years, but it's worth a conversation. We do recommend that you have an annual review. So they're the main things covered. I'm just going to come out of that screen. And we've got some time for questions. So if anybody has any questions, I have to keep it quite general, but I'm happy to answer any questions that people may have. I'll look out for any raised hands. Zoe, do you want to unmute yourself? Hello.
Hello. When you go on HRT, is it similar to being on the pill in terms of how it feels? I was on a pill a long time ago now, before I had my kids, and they swapped me to one that they said was exactly the same, and I totally lost the plot. I was nauseous, I was weepy, and they'd said it was exactly the same. So I'm really nervous about taking anything hormonal, but I'm sure it's come on in the last 20 years or whatever it was.
It has. So HRT, now that we have body identical natural forms of HRT, often women will find that they can take that much more easily than older synthetic types of contraceptive pill. So often women will find that they have fewer side effects and they tolerate the natural body identical forms of HRT that are available now. It might also be, even if it was the same pill that you took, our bodies change quite a lot during pregnancy, and after having children, our side effects to synthetic hormones can change, and the reactiveness of the lining of the womb, for example. So periods often change, but yeah, it might be that it's because of pregnancy in the middle that's changed.
Yeah, I didn't go back on it after pregnancy. I got my husband to have the snip instead. But yeah, it was early on, and it was when there was the scare about blood clots. My pill was one of the ones that was in that, and they just switched me. I guess I was in my early 20s maybe.
Oh, I see.
And
Yeah.
and just overnight, I just didn't recognize myself. It was horrible.
Yes, so that can happen. Sometimes that's to do with the synthetic progestogen component of older sort of oral contraceptive pills that people have sensitivity to, and that can really affect the way women feel. But natural body identical HRT options that are available now do tend to be tolerated much better with fewer side effects.
Okay. Just planning on when to start, and do I need to leave a gap where I've got less commitments in case I lose the plot?
Well, you can phase HRT in as well. So you can start at a low dose and slowly increase. There are ways to tailor it around things. So yeah, there'll be a way to do it that fits with your current lifestyle and stresses. Yeah,
Thank you.
you're welcome. Any other questions at all? Deborah, hello.
Hi there. I've been on HRT for a couple of years now, 2 years, and I thought I was pretty optimized, but I seem to be falling apart again. I'm on everything, including testosterone. How do I know when I'm kind of optimized, and how do I have the battle with the doctors about upping it or changing it?
Yeah. So
Lots of questions there, sorry.
that's okay. So optimizing HRT is always the aim, and often it can feel like your HRT regime is optimized and you have reduction of symptoms and you feel like everything's going well, and then things can change, and this can be for various factors. So of course it can be to do with external stresses and things that can sort of tip us over the edge of feeling like we're coping, but also it can be directly influenced by our stage that we're at. So in the perimenopause, estrogen requirements can change as you go through the perimenopause. For some women, earlier on, the symptoms are worse, and you need a really decent dose of estrogen to help stabilize hormonal fluctuations. But as women approach the average age of the menopause, which is 51 in the UK for the majority of women, estrogen requirements can go up a bit. And sometimes we do need to increase the estrogen dose and titrate the dose to symptoms. So, for example, women who get vasomotor symptoms like hot flushes or night sweats, that's quite a good barometer for estrogen requirement. But another thing that can happen is that because we're taking it through our skin, there are loads of different factors that affect how effectively we absorb estrogen through the skin transdermally. And sometimes we can be using one product, like a patch, for example, that's working really well. And then for some reason, we stop absorbing it as effectively. And so estrogen levels can drop, or our hormonal fluctuations aren't managed as effectively. And you get a return of symptoms. So often at that stage, I would be talking about either increasing the estrogen dose a little bit or changing to a different type. So, for example, changing from a patch to a gel or vice versa.
So I'm on gel at the moment. I've got gel estrogen and gel testosterone.
Yeah.
Which I feel like I'm out of control. So maybe just up the estrogen a little bit.
Possibly, it's having a conversation. Sometimes we, depending on the stage you're at, we do blood tests as well if we're worried about absorption, but it really depends on where you are. Sometimes it's not appropriate to do a blood test. But yeah, there are different options. Yeah, changing the type of estrogen can be really effective for some women. So changing to, for example, can be quite effective, and can sometimes mean that you don't necessarily need to increase the dose. You just start to absorb more effectively from a different method.
Okay, perfect. Thank you.
That's okay.
Thank you.
Any other questions? Yes, Zoe.
Can I ask one more? If you go onto HRT, is there a chance that it could mask symptoms that are about something else? I've been looking at my metabolic health, and even though I'm active every day, I'm vegan, I don't drink, I'm putting weight on. I'm heavier than I've ever been, and I've upped my exercise, but nothing seems to touch it. And I don't know if that's connected with menopause, or I need to sort my metabolic health out first and then look at HRT. But I'm worried that would going on HRT when I haven't sorted that out mask something else that could be going on?
No, it wouldn't. It wouldn't mask symptoms, and those things can be happening at the same time. So tackling all of these things at the same time, or in parallel, can be really helpful. So trying to improve metabolism through lifestyle and the things that you're already doing can be really effective. But adding in natural body identical HRT, it doesn't necessarily help you. It doesn't directly cause weight loss, for example, but being on estrogen can help to manage blood sugar and insulin control, for example, and can improve metabolic health. So with a healthy lifestyle, often women find that it's easier to maintain healthy weights or easier to lose weight through these other means. So you can do the things at the same time. It wouldn't mask symptoms. No, being on HRT doesn't mask symptoms.
But if for example, that my metabolic health not being good is kind of causing the word finding issues and the weight gain and stuff, if I then go on HRT and I didn't need to, is that dangerous or is it okay?
It's not dangerous, no, and I think we would normally talk about we usually suggest a 3-month trial of being on HRT. So if you start taking HRT and you don't feel that it's helped at all, it's not improving your symptoms, then we would have a conversation about either tweaking it or making changes or not continuing with it if you just don't feel like it's helping at all. And that we would balance, potential side effects with benefits and the time scale of those. But yeah, it wouldn't be harmful to your metabolic health, and it wouldn't mask things. No.
Thank you.
Okay. Any other questions? Okay. Oh, well, it's great that so many of you could attend today. Tia has recorded this presentation, so it will be available afterwards as well. And look out for more presentations and webinars that we'll do in the future, and for blogs on our website that's updated regularly. So there are lots of blogs on there. And if you have any questions, you can always contact us at the clinic as well. Okay. Well, it's nice to see you all. You're very welcome. Bye for now.
Thank you.
Thank you.
Very welcome.
Thank you. Bye.
Bye.